So we are going to just do a quick review of what we went over in class on Tuesday. So the nursing process, part of the assessment piece of it, was going over what to do in an emergency setting with wounds. So just a quick review. We want to stabilize the patient's cardiopulmonary status. Remember, we do CAB, circulation, airway, breathing. We're going to assess for bleeding and take care of any hemorrhaging that may be going on. And then just a quick review of types of wounds. We have abrasion, which is a stage 2, laceration, and puncture wounds. These are common emergency setting wounds that you may come in contact with. And then we want to determine if there is a need for a tetanus toxoid injection. The next slide that we're going to cover is wounds in a stable setting. So once an acute wound is stable, maybe after surgery or treatment, we want to assess the progress of the wound, meaning is it healing? So if a dressing covers the wound and there are orders not to change it, inspect the dressing and any external drains. So there may be a drain that is attached to the wound to help drain some fluid or some blood. If a dressing appears saturated with drainage, reinforce the dressing and notify the patient's primary nurse and healthcare provider immediately. So why do we think it is so important to notify a healthcare provider in this situation where the dressing is becoming saturated? And the reason is because a saturated dressing can provide a really great environment for bacterial growth. And we want to help prevent that bacterial growth or the risk for infection. So if we do have some purulent drainage or copious amounts or large amounts of drainage, we really do want to notify the healthcare provider. When we plan a dressing change, we also want to consider the patient and their pain levels, or what their pain levels may come to. So we would want to offer them an analgesic at least 30 minutes before exposing a wound. And that will give the medication enough time to really kick in and provide relief if needed. So first we want to inspect the appearance of the wound, noting the location, the size, the approximation of the wound edges, meaning how well are the edges starting to come together, the presence and quality of any exudate or drainage, the type of tissue in the open wound. So am I seeing granulation tissue, like a red moist tissue, or is it sort of yellow in color? And also the skin integrity around the wound, and any signs of dehiscence, evisceration, or infection. Then I'm going to assess the character of the wound drainage. So how much drainage? What is the color, the odor, and the consistency? Different types of drainage include serous, which is like a clear, watery plasma, sanguineous, which is fresh blood, serosanguineous, pale, more watery. It's usually a combination of plasma and red cells, and it could be blood-streaked, and purulent, which is thick, yellow, green, or brown, usually indicating the presence of dead or living organisms and white blood cells. So we have serous, which is like a whitish, clearish color, sometimes can be a little pale yellow, sanguineous, which is bloody, serosanguineous, which is usually a little bit of the clear white fluid with some blood streaked in it, and then purulent, which we said was usually thick, yellow, green, or brown, indicating the presence of dead or living organisms and also white blood cells. So if you ever have a wound where the drainage has a pungent or strong odor, an infection is likely. So we want to document the integrity of the wound and the character of the drainage, describing the appearance by observable characteristics, meaning what do I see exactly? So I'm going to be stating exact facts. Next, we move down to the presence of drains. The presence of drains is also another important assessment piece. A drain is used in a surgical wound if a healthcare provider expects a large amount of drainage. And this drain is going to help gather that drainage to assist in the healing process so that we don't have too much drainage, which could interfere with the healing process. In the case of a surgical wound, we always want to inspect staples, sutures, or stitches, or wound closures for irritation, and we also want to note whether the wound edges themselves are intact or together. When a wound starts to exhibit swelling, separation of its edges, or redness in the wound area, it is important to evaluate for the presence of something called cellulitis. Cellulitis is generally red in color, warm to touch, and sometimes appears as if it's a rash-like manifestation. Lastly, for pain assessment. Pain assessment is an important component of wound assessment for detecting complications and planning for future wound care. So not only do we want to assess for pain before we do a dressing change, but we also want to assess for pain within the wound itself in general, whether it be before, after, or during a dressing change. If this patient is experiencing severe pain when the wound is not even being touched, that may be significant as far as complications are concerned. It will also assist us in planning for future dressing changes. Next, we move on to wound cultures. So if we detect any clinical symptoms that suggest a wound infection, we should do a wound culture. So, some symptoms of wound infection: increased erythema, increase in the amount or change in character of exudate or drainage, odor, increased local warmth or systemic signs of infection, such as fever, chills, or an increased white blood cell count or leukocytosis. We never want to collect a wound culture sample from old drainage because resident colonies of bacteria grow in the exudate. So we want to clean the wound to remove skin flora first, and then we will obtain our culture. So clean the wound first and then obtain the culture. Box 37-8 in the textbook does describe the procedure used to collect an aerobic specimen, which is aerobic versus anaerobic. So aerobic organisms grow in superficial wounds that are exposed to the air, whereas anaerobic organisms tend to live in body cavities. And I think aerobic and air, as if you're doing aerobics to exercise, right? You get short of breath, short of air. So that's how I remember aerobic. And aerobic organisms grow in superficial wounds that are exposed to air, whereas anaerobic tend to live within body cavities themselves. This just goes over the steps of collecting an aerobic specimen. So, prepare to collect the specimen using sterile technique. So this we would want to do before administering any antibiotics. Because if I administer antibiotics, I am not going to find out what that true organism or true bug is that is growing within this wound. Clean the wound surface with an antiseptic solution. Moisten the swab with normal saline. And while applying pressure, I want to rotate the applicator, which generally looks like a long Q-tip, within 1 to 2 centimeters squared of clean wound tissue. Once the tip is saturated, I want to insert it into the sterile container. I will complete a laboratory slip, providing clinical data, and transport it quickly, usually within 1 hour, to the laboratory to keep the specimens stable. So that is for an aerobic. Remember, aerobic we talked about, superficial, exposed to the air. Now we're going to talk about specimen collection for anaerobic. To collect an anaerobic specimen deep in a body cavity, we would use a sterile 10 milliliter syringe with a 22 gauge needle. Do not worry about the size of the syringe or the gauge of the needle. This is just letting us know that we have to use a certain size with a certain size needle with a certain size syringe. You don't have to know this for your tests. It says to aspirate 5 milliliters of air into the syringe. After cleaning the skin with a disinfectant and allowing it to dry, insert a needle into the wound and aspirate wound drainage while moving the needle back and forth in 2 to 4 areas of the wound. Withdraw the needle from the wound and expel any air from the syringe. Inject contents from the syringe into a special vacuum container with culture medium. In some institutions, you will place a cork over the needle to prevent entrance of air and send the syringe to the laboratory. Now, I have never used this type of culture in a wound, and you very well may, it just depends on the facility where you work. But I have only performed an aerobic specimen collection, never an anaerobic specimen collection. Okay, so patient expectations. Because our patients need to be involved with wound care management, it is really important to know what his or her expectations are of us as the nurses. So a patient who unrealistically expects rapid wound healing is going to be very easily discouraged and may not follow the treatment plan. So we need to be very upfront and realistic with our patients that depending on the type of wound that they have, it may take longer to heal. At the same time, a patient who knows the process knows that it could be lengthy and may unrealistically expect the wound area to heal, possibly without scarring, for example. So, knowing these expectations, meaning the expectations of our patients, will help us provide an individualized care and help a patient modify expectations when they're needed. So it's all about being realistic with our patients. Let's review this case study together. So we have Linda. Linda reviews the nursing assessment and finds that Mr. Ahmed was admitted with a pressure ulcer. The ulcer is a stage 2, 1 by 2 inch and 1/8 of an inch deep, partial thickness wound over his sacral area. No necrotic tissue is present, and the wound bed has red, moist tissue. When Linda prepares to conduct the skin assessment, she recalls information about the pathogenesis of presence of pressure ulcers and guidelines for skin assessment for patients with darkly pigmented skin. So, in order for us to really make sure that this is a stage 2, why don't we do a quick review of the stages and their descriptions so that we really can determine that Mr. Ahmed has a stage 2 pressure ulcer. So let's start from the beginning. Stage 1, non-blanchable redness, and the skin is intact. Stage 2, partial thickness skin loss or blister. And in Mr. Ahmed's case, it says that his wound is a partial thickness wound over his sacral area. So that's how we know it is a stage 2. A stage 3 is full thickness skin loss with fat visible. And a stage 4 is full thickness tissue loss with muscle and bone visible, and/or bone. Tendons can also be visible. In dark-skinned people, the compromised area may appear dark blue or purple instead of red. Linda observed care of a stage 4 pressure ulcer during an experience in an extended care facility. From that experience, she increased her knowledge about the debilitating effects of pressure ulcers. In addition, she was able to practice skin assessment techniques during her clinical experience in the extended care facility. So this is when we go over that critical thinking slide, and Linda used her previous experience to help care for Mr. Ahmed. In going through the case study further, we have, what do we think would be the appropriate nursing diagnosis for Mr. Ahmed and his situation? So we identify the support surface that would be appropriate to decrease pressure on Mr. Ahmed's skin. So Mr. Ahmed cannot tolerate positions that might relieve or reduce pressure to his skin. We inspect and palpate the wound. The wound is 1 by 2 inches, full thickness ulcer over the sacral area with a red moist base. Reddened peri-wound skin. And then we conduct a calorie count. So these are some of the interventions that we are going to do. Mr. Ahmed is eating fewer than 1,600 calories a day. So what do we think would be an appropriate nursing diagnosis for Mr. Ahmed? An appropriate diagnosis would be impaired skin integrity related to pressure over bony prominence in sacral region. So that's just an example of what would be an appropriate nursing diagnosis for Mr. Ahmed. We're now going to move forward to the diagnosis piece, as we just gave an example. And here are a few more examples of some nursing diagnoses that would be appropriate for skin integrity and wound care. So we have risk for infection, impaired bed mobility, impaired physical mobility, imbalanced nutrition, less than body requirements, acute pain, chronic pain, impaired skin integrity, risk for impaired skin integrity, and ineffective peripheral tissue perfusion. Now for Mr. Ahmed, if we were to look between impaired skin integrity and risk for impaired skin integrity, we would definitely choose impaired skin integrity because he does have a stage 2 pressure ulcer. We also want to make sure that while we're choosing our nursing diagnosis, we are assessing for related factors that contribute to each diagnostic statement. So these related factors become the focus within our interventions. Let's move on now to the planning part of the nursing process. So we need to develop patient-centered goals aimed at preventing or reducing impaired skin integrity or promoting wound healing. Individualized care planning for the patient, taking into consideration his or her most immediate needs. Assess all patients for the risk for skin breakdown and perform skin and wound assessments daily. Integrate information from the pressure ulcer risk and skin assessments into the plan of care and write attainable goals. So goals that we can actually achieve. In the textbook, figure 37.7 goes over a concept map and a care plan related to impaired skin integrity. So this is a really great example of how to write a full care plan. When planning care, we want to establish priorities based on comprehensive assessment, goals, and expected outcomes. So what have we compiled? What evidence and information have we as the nurse assessed and gathered? We want to make sure that we are meeting our patients' acute and immediate needs. We also want to prioritize preventative interventions and implement them in a timely manner. So yes, we need to make sure that we are meeting their immediate needs, but also make sure that we're providing education and interventions on preventative measures as well to prevent future problems. Maintenance of skin integrity and promotion of wound healing prevent additional healthcare issues, which in the end is obviously our ultimate goal. Anticipating a patient's discharge from an acute care institution and referral to a skilled nursing care facility or home care agency is necessary to help a patient remain mobile or regain mobility at home. So this is where we start to collaborate with other members of the healthcare team, such as social services and case management, as well as physical therapy and occupational therapy. Patients and their families often need to continue wound management after discharge. They need to discuss the likelihood that the patient will return home, needing the assistance of home health nurses or transfer to a skilled nursing facility for more care and observation. So like I said, we are going to consult with the case manager to plan for the necessary resources for support once a patient is discharged. Include a physical therapist for evaluation of a patient's ability to transfer and walk upstairs, if there are stairs within their home. If there are not stairs within their home, then that would not be a huge concern for us at that time. Also, consult with a registered dietitian to assist a patient's nutritional status and help with nutrition interventions, such as a higher calorie, especially high protein diet. Because remember, protein will help assist with the healing process. Quick quiz. Let's go over this question together. The nursing assistant asks you the difference between a wound that heals by primary or secondary intention. You will reply that a wound heals by primary intention when the skin edges A. are approximated, B. migrate across the incision, C. appear slightly pink, or D. slightly overlap with each other. So if we use the STOP acronym to answer this question, first I'm going to ask myself, what is the story? So the story is, I have a nursing assistant who wants to know the difference between primary and secondary intention regarding wound healing. Think. What is the question? What are they asking me? A wound heals by primary intention when the skin edges what? So I need to know how it heals by primary intention. Oh, look at all my option choices. So, a wound heals by primary intention when the skin edges A. are approximated. Yes, that's true when they start coming together. B. migrate across the incision. Well, are the skin edges actually migrating across the incision? In class, we talked about how the epithelial cells kind of slide across a moist environment to assist with the healing process, but not necessarily the skin edges themselves. C. appear slightly pink. We talked about red granulation tissue, but slightly pink is not quite red granulation tissue, so I would probably knock letter C out of my option choices. And D. slightly overlap each other. We never want wound edges to overlap each other. They should come together in a smooth-like manner. So if I were to go back, I would pick my appropriate answer, which would be A. A wound heals by primary intention when the skin edges are approximated. Returning back to our case study, it is important to set achievable goals and expected outcomes for the patient. So our goal for Mr. Ahmed would be pressure will be reduced to the sacral area and the wound will show movement toward healing in 1 week. Don't forget we have that timeline associated, the 1 week. Expected outcomes, wound will decrease in diameter in 7 days. No evidence of further wound formation will be noted in 3 days. And we have days again associated as part of our goal. Implementation is the next step in the nursing process. So, it is important that we perform skin assessments daily, paying special attention to bony prominences, and never massage a reddened area. So why should you avoid rubbing reddened areas? Avoid rubbing reddened areas because reddened areas indicate that there is tissue injury. and we do not want to cause more harm to the already injured tissue. When cleansing the skin, we want to use a mild cleansing agent. Soap causes dryness, which increases the risk for skin infection. Skin lubrication helps keep the skin intact, so consider using a moisturizer on a routine basis. Intact skin is the initial defense for preventing skin breakdown. Keep your patient's skin clean and dry. Many types of products are available for skin care. Match their uses to the specific needs of your patient. Use an incontinence cleanser for a patient who is incontinent of stool or urine. To protect the skin, apply a moisture barrier product, generally petroleum or dimethicone based. So apply this liberally to the exposed area. The moisture barrier provides skin protection from the irritating effects of stool or urine and allows you to clean the next incontinent episode easily. Apply the moisture barrier ointment after each cleansing. For skin that has become exposed or stripped from incontinence, use a barrier paste that adheres to the irritated area and will not be removed with each cleansing. Because if I were to remove that with each cleansing on the irritated skin, I would only cause more harm and more irritation to that specific area. You can contain fecal incontinence with a fecal incontinence collector, in which an adhesive skin barrier is attached to a drainable pouch applied around the anus to collect liquid stool. An example is the picture shown on the slide. Use a fecal incontinence collector when a patient is experiencing frequent liquid bowel movements and has intact perianal skin. Other external collection devices include male external catheters applied to the shaft of the penis to collect urine. You can use underpads and diapers, or we should really refer to them as depends, or briefs, to protect skin in patients incontinent of stool and urine. Select underpads or briefs that are absorbent to wick incontinence moisture away from the skin rather than trap it against the skin, which causes maceration or softening of the skin caused by moisture. So we would want to choose products that wick that moisture away from the skin instead of having that moisture sitting up against the skin. When providing skin care to a patient who is incontinent, the healthcare team first assesses and treats the cause of the incontinence and then decides on protection and/or collection interventions. Within the implementation piece of the nursing process, this is where we talk about health promotion, and particularly positioning. Positioning interventions reduce pressure and shear. Repositioning frequency is determined by tissue tolerance, level of activity and mobility, general medical condition, overall treatment objectives, and support surface. A standard turning interval of 1 to 2 hours does not prevent pressure sore development in some patients. Recommendations to reduce shearing by keeping a patient's head of bed below the 30-degree angle is suggested. Also, utilizing assistive devices when turning or transferring patients, using the bed footboard, and using the 30-degree lateral position. As you can see on the picture on the slide, that is the 30-degree lateral position. So you are positioning your patient on their side at 30 degrees to help relieve pressure, specifically here off the sacrum and their left side. When a patient is able to sit in a chair, reposition him or her every hour. Assist or teach patients with the ability to shift weight to reposition every 15 minutes. So whether the patient is in bed or in a chair, If they can shift weight themselves, they need to do so every 15 minutes. If they are unable to shift their weight themselves, if they are in a chair, we need to reposition them every hour. If they are in a bed and unable to shift their weight, we need to reposition them every 2 hours. A gel or air cushion can be used to redistribute the patient's weight while sitting in a chair to help decrease the amount of weight on the ischial tuberosities. So basically, their bottom. By using a gel cushion or an air cushion, this will help redistribute their weight and decrease pressure points. Using a donut-shaped cushion actually increases pressure around the shape of the donut and is not recommended. A patient's heels are an area of concern because of the small surface area. Keep heels off the bed with a pillow under the lower leg or by the use of a heel protector. Support surfaces decrease the amount of pressure exerted over bony prominences by maximizing contact or allowing the body to touch the entire surface, and thereby redistributing weight over a large area. Support surfaces include mattresses, overlays, framed specialty beds, chair pads, table pads, and crib mattresses or pads. Table 37.3 in your textbook provides an overview of support surfaces. In addition to redistributing pressure, many of the support surfaces reduce shear and friction and decrease moisture. A flow diagram like the one in figure 3711 in your textbook helps you in clinical decision making, specifically regarding an appropriate support surface based on your assessment findings. Remember, even when using a support surface, you still need to reposition your patient. Once a support surface is in use, reevaluate a patient on a frequent basis. Although it is important for all patients, nutrition is of particular importance for a patient with a wound to prevent severe or prolonged depletion of nutrients that can impact healing. Complete a nutritional assessment on a patient who has a wound, collecting important data such as relevant patient history and laboratory data. Consider consulting with a registered dietitian to obtain a thorough evaluation of the patient's nutritional status and identify related interventions to improve nutritional intake. Note that the first two actions address pressure management. So, post and implement a turning schedule. And the other one says obtain and place over the patient's mattress a low air loss overlay. So these first two actions address pressure management. The next two address wound care. So clean wound and peri-wound skin, dry peri-wound skin. And then apply a hydrocolloid dressing to the wound. And the final intervention addresses nutrition management. Determine an appropriate diet in collaboration with a dietitian. So, for the first one, post and implement a turning schedule. Why would I do that? Repositioning the patient is going to redistribute the pressure. For the second intervention, obtaining and placing the patient's mattress with a low air loss overlay. A mattress overlay redistributes the amount of pressure on the bony prominences. The third intervention, cleaning the wound and peri-wound skin and drying the peri-wound skin. Cleansing the wound and the peri-wound skin will help remove debris and old drainage from the site, thus preventing further wound progression and skin breakdown. The fourth intervention, applying a hydrocolloid dressing to the wound. The use of this type of dressing, hydrocolloid, will support a moist wound healing environment, and it will also help protect the wound. And lastly, the fifth intervention, determine in collaboration with the dietitian an appropriate diet, adequate nutrition such as protein intake, increased calorie count, and vitamins all aid in wound healing. We are now going to move to acute care setting, which would be more like a hospital setting. So we would still apply wound management principles. We would provide appropriate wound management, including managing the pressure, shear, friction, and moisture. We would provide systemic support to enhance our patient's wound healing. Because hyperglycemia or high blood sugar impairs wound healing, blood glucose control is essential. And I'll say that again, this piece is very important, not just to know, but I believe it is on your test as well. It is important to know, because hyperglycemia or high blood sugar impairs wound healing, blood glucose control is essential. And we've talked about this numerous times in class, how we have our blood, and if there's a lot of glucose within our blood, it becomes sticky and sluggish, more or less. Therefore, it is more difficult to get to the areas of the wound to provide nourishment and capabilities of healing. A stable wound environment and appropriate treatment are necessary to promote healing. To maintain a stable environment, it is important to control infection and promote cleansing, debride or remove necrotic tissue, provide exudate management, control dead space, and provide wound protection. Table 37.4 in your textbook describes treatment options by each ulcer stage. It is important to involve a patient's family or caregiver in management of pressure ulcers and their treatment. Frequently, patients require dressing changes after discharge. The patient's family or caregiver is an excellent source for dressing support and identification of possible wound healing complications. Box 3712 in your textbook provides patient teaching information for pressure ulcer dressing changes. First aid for wounds. When a patient suffers a traumatic wound, first aid interventions include promoting hemostasis, cleansing the wound, and protecting the wound from further injury. So after assessing the type and extent of the wound, we want to control bleeding from a laceration by applying direct pressure to the wound with a sterile or clean dressing. After the bleeding subsides, an adhesive dressing strip or gauze dressing taped over the laceration allows the skin edges to close and a blood clot to form. If a dressing becomes saturated with blood, add another layer of dressing. Continue to apply pressure and elevate the affected part. A healthcare provider sutures serious lacerations in an emergency clinic or hospital. If a penetrating object such as a knife blade is in a patient's body, do not remove the object. Removal causes massive, uncontrolled bleeding. Apply pressure around the object, but not on it or on surrounding tissues. For abrasions, minor lacerations, and small puncture wounds, rinse the wound in running water. Gently cleanse with mild soap and water, rinse, and apply an over-the-counter antiseptic. When a laceration is bleeding profusely, Only brush away surface contaminants and concentrate on hemostasis until the patient reaches a clinic or hospital. Protect the wound by applying a sterile or clean dressing and immobilize the body part. A light dressing applied over minor wounds prevents entrance of microorganisms. In the case of small abrasions, it is appropriate to leave the wound open to air so a scab forms. The more extensive the wound, the larger the dressing required. In a home emergency, a clean towel or diaper is often the best dressing. A bulky dressing applied with pressure minimizes movement of underlying tissues and helps to immobilize the entire body part. A dressing or cloth wrapped around a penetrating object immobilizes it adequately. A variety of dressing materials are available commercially. The choice of dressing and how it is applied influence wound healing. Ideally, a dressing provides a moist environment to promote normal epidermal cell migration and also absorbs drainage to prevent bacterial growth. It discourages the exposure of a wound to microorganisms. However, if a wound has minimal drainage, the natural formation of a fibrin seal eliminates the need for a dressing. A pressure dressing promotes hemostasis by exerting localized downward pressure over an actual or potential bleeding site. A moist dressing lightly packed into the wound fosters normal healing by eliminating dead space in underlying tissues. A dry dressing promotes healing by allowing the wound to heal by primary intention and absorbing minimal oozing of wound drainage. When a wound is healing by secondary intention, use a dressing to provide a moist environment. A firmly taped or wrapped dressing supports or immobilizes a body part, minimizing movement of the underlying incision and traumatized tissues. Finally, a dressing promotes thermal insulation to the wound surface and protects it from the dehydrating effects of air. Dressings vary by type of material and mode of application, dry or moist. They are easy to apply, comfortable, and made of materials that promote wound healing. Gauze is the most common dressing type. It does not interact with wound tissue and thus causes little wound irritation. Gauze dressings are best for wounds with moderate drainage, deep wounds, undermining, and tunnels. Apply gauze either moist or dry. It is very important that you understand the different types of dressings and when they should be applied. So we would apply gauze dressings. These are best for wounds with moderate drainage, deep wounds, undermining, and tunnels. Gauze can be applied dry or moist. And again, they are best for wounds with moderate drainage. Transparent film dressings are clear sheets coated on one side with an adhesive. The adhesive side does not stick to the wound because of the moisture and it traps over the wound bed, providing a moist environment. The film is impermeable to fluid, but semi-permeable to oxygen. So fluid cannot get in, but oxygen can. This type of dressing is used as a primary dressing in wounds with minimal tissue loss that have very little wound drainage. So transparent film, it's a clear adhesive sheet that is used in wounds with minimal tissue loss and those that have very little wound drainage. Hydrocolloid dressings are made of gelling agents and have an adhesive wound surface. Hydrocolloid gelling agent. Hydrocolloids form a gel as they interact with the wound surface. Because they are occlusive, they protect the wound from surface contaminants, and you can leave them over a wound for several days. When removed, you will note a gel over the wound base. The gel maintains a moist environment to support healing and washes away during wound cleansing. So hydrocolloid is a gelling agent, and it can be left on for several days. Hydrogel dressings are available in sheets or in a gel in a tube. They contain a high percentage of water and are indicated for wounds that require moisture, either a wound with granulation, maintaining the moist wound environment needed for healing, or a wound that has a high percentage of necrotic tissue. So the hydrogel will help facilitate debridement by softening that dead tissue and allowing that dead tissue to come off. Hydrogels maintain moisture in some wounds for 1 to 3 days. So hydrogel contains a high percentage of water. Hydrogel, water. Hydro, water. And it's indicated for wounds that require moisture, and also for wounds that have a very high percentage of necrotic tissue, because the hydrogel is going to provide such a moist environment that it's going to help debride or remove that dead tissue by softening it. Hydrogels maintain moisture in some wounds for 1 to 3 days. Next, we move on to negative pressure wound therapy, also known as a wound vac. Negative pressure wound therapy uses negative pressure to help wound healing. Negative pressure wound therapy supports wound healing by evacuating wound fluids, stimulating granulation tissue formation, reducing the bacterial burden of a wound, and maintaining a moist wound environment. So they do numerous things to assist in wound healing. Apply negative pressure wound therapy by fitting the foam or dressing to the shape of the wound and placing a drainage or suction tube in the interior or on top of the dressing. Seal the dressing and the tube with a transparent dressing and connect the tube to a prescribed amount of negative pressure, which creates a suction. We will watch a video on Friday describing the application of negative pressure wound therapy. The suction will pull all air out of the wound and create an airtight seal. This therapy provides removal of excess wound fluid to stimulate granulation tissue and to decrease wound bacteria. Current evidence shows that this therapy often reduces healing time in chronic wounds and results in early grafting of wounds. To prepare to change a dressing, you need to know the type of dressing, any underlying drains used, and the type of supplies needed for wound care. You can adjust the type and amount of dressings if the amount of drainage changes or a wound becomes deeper. Notifying the healthcare provider of any change is essential. The order for changing a dressing usually indicates the dressing type, frequency of changing, as well as the solution or ointment you will apply. A patient's medical or operating room record usually reveals whether drains are present. After the initial dressing change, communicate on the care plan the type of dressing materials and solutions to use and the type and location of drains. Use aseptic technique during dressing change procedures. It is also essential for a patient to understand the steps of the procedure beforehand to help reduce anxiety. Describe normal signs of the healing process and offer to answer questions about the procedure or the wound. If a patient needs to care for a wound at home, demonstrate dressing changes and provide an opportunity for the patient and family to practice. In your book, review skill 37.4, applying dressings. Dry, moist, and transparent. Again, that's skill 37.4, applying dressings. Use tape, ties, or dressings, and cloth binders to secure a dressing over a wound site. Binders are dressings made of large pieces of material to fit a specific body part. An arm sling is an example of a binder. A binder reduces stress on a wound. The choice of anchoring depends on the wound size, location, drainage, frequency of dressing changes, and the patient's level of activity. You most often use tape strips to secure dressings if the patient does not react to tape. Hypoallergenic paper, plastic, and woven fabric tapes minimize skin reactions. To avoid repeated removal of tape from sensitive skin, secure dressings with reusable Montgomery ties, which are shown in the picture above. Each tie consists of a long strip. Half contains an adhesive backing to apply to the skin, and the other half folds back and contains a cloth tie that you tie across a dressing and untie at dressing changes. A long dressing may require 2 or more sets of Montgomery ties. I have used quite a few Montgomery ties in my days, and I really do enjoy them. They are very easy to use, user-friendly, and more comfortable for a patient, so you're not constantly irritating their skin with tape. To provide even support to a wound and immobilize a body part, apply elastic gauze or cloth dressings and binders over a dressing. Any wound can be painful depending on the extent of tissue injury. Interventions for pain reduction during dressing changes include allowing timeouts during painful procedures, so allowing a break to the patient, scheduling dressing changes when a patient is feeling best, soaking dry dressings before removal so that we're not tearing off good tissue, and avoiding aggressive packing. Positioning and supporting the wound area for comfort, and considering using low adhesive or non-adhesive dressings are also very important. And I would say the biggest piece of advice, and an absolute must, is if the patient does have pain medication available to them, always offer it to them within 30 minutes or 30 minutes before scheduling a dressing change. Okay, quick quiz. A surgical wound requires a hydrogel dressing. The primary advantage of this type of dressing is that it provides A, an absorbent surface to collect wound drainage, B, decreased incidence of skin maceration, C, protection from the external environment, or D, moisture needed for wound healing. So let's use the STOP acronym to answer this question. S is for story. So what is my story? I have a wound that is requiring a hydrogel dressing. Think, or T stands for think. Think about what is it asking me. What is the primary advantage of using a hydrogel dressing? Oh, look at all my option choices. An absorbent surface to collect wound drainage. Hydrogel, nothing was described when we talked about hydrogel as far as an absorbent surface. So I would have to put an X next to A. B, decreased incidence of skin maceration. I know hydrogel is a good thing. It's a good type of dressing. And I don't know that it necessarily is going to help decrease skin maceration, because maceration is bad. But I didn't really ever see a correlation between hydrogel dressings and decreasing skin maceration. That was not discussed. Letter C, protection from the external environment. Sure, if I'm putting a water-based gel over top of a dressing, I would hope that it would help protect the external environment. But the question is asking me, what is the primary advantage of this type of dressing? So let's look at D. Moisture needed for wound healing. I absolutely do need moisture to assist with wound healing. And as we talked about before, hydrogel is going to provide that for us. So out of my last choices that I have left between C and D, the primary advantage of using a hydrogel dressing is D, moisture needed for wound healing. Wound cleansing removes surface bacteria, preventing the invasion of healthy tissue. Normal saline effectively cleans when delivered to the wound site with adequate force to agitate and wash away bacteria. Do not use povidone iodine or betadine, hydrogen peroxide, and acetic acid to irrigate a clean, granular wound. These solutions are toxic to fibroblasts, a key cellular component in wound healing. So when cleansing a wound, we want to cleanse from the least contaminated area to the most contaminated area, so that we don't contaminate the clean areas with the dirty parts. Use light friction when applying antiseptics, and irrigate from the least contaminated to the most contaminated area. When cleaning a drain site, cleanse in a direction from the least contaminated area to the most contaminated area. Irrigation is a way of cleansing wounds of exudate and debris. You use an irrigating syringe to flush the area with a constant flow of solution. Irrigations are useful for cleaning open, deep wounds or sensitive or inaccessible body parts. Administer the prescribed solution, usually normal saline, at body temperature to enhance comfort and provide local cleansing application. When irrigating a clean wound, use sterile technique and an irrigation system with a safe level of pressure. And it's 4 to 15 psi. Do not worry about memorizing that. The importance, though, of this amount of pressure is to prevent trauma to the newly formed granulation tissue. So I don't want to apply too much pressure, because then I can damage that newly formed granulation tissue. This method provides an ideal solution pressure for cleansing the wound while also minimizing tissue trauma. Make sure that the syringe tip is over but not sticking into the wound. And you can see the syringe tip in the picture. It is like a soft, flexible catheter and not a metal needle. So just so you know, it's a soft, flexible catheter that would be used, not necessarily a metal needle. A surgeon closes a wound by bringing the edges as close together as possible to reduce the formation of scar tissue while minimizing trauma and tension and controlling bleeding. Sutures are threads or wires made of silk, steel, cotton, nylon, and polyester, and are used to sew body tissues together. Darcan or polyester sutures minimize scar formation. Surgeons frequently use steel staples, a type of outer skin closure, because they result in less tissue trauma while providing extra strength. Wounds can also be closed with steri-strips, a sterile tape applied along both sides of a wound to keep the edges closed. These are examples of steri strips on this slide here. Be familiar with the types of suture methods. Policies vary among institutions as to who removes sutures. If you remove sutures, a healthcare provider's order is absolutely necessary. And you don't, for your tests, need to know the different types of sutures, but just for your information, A is known as intermittent, so this is the type of suture method for picture A. Picture B is continuous suture method. Picture C is blanket continuous. And picture D is retention suture method. When drainage interferes with healing, drainage evacuation is achieved by using a drain or a drainage tube with continuous suction. Drainage evacuations are convenient, portable units that connect to tubular drains within a wound bed and exert a safe, constant, low-pressure vacuum to remove and collect drainage. Ensure that suction is exerted and that all connection points between the evacuator and the tubing are intact. The evacuator, which in the case of the picture here, the bulb itself where the nurse is holding her hands, the evacuator collects drainage that is assessed for volume and character. When the evacuator fills, measure output by emptying the contents into a graduated cylinder or medicine cup and immediately reset the evacuator to apply suction. So in the picture here, this is known as a Jackson-Pratt drain or a JP drain. Most likely when you go to level 2 and you are in the hospital setting, you will see quite a few JP drains. Bandages and binders are applied over or around dressings to provide extra protection and also therapeutic benefits by creating pressure over a body part. They also help immobilize a body part, support a wound, reduce or prevent edema, and secure a splint or secure dressings. Correctly apply dressings and binders as to not cause injury to underlying or nearby body parts, and make sure not to create any discomfort for the patient while applying a dressing or binder. We want to inspect the skin abrasions, edema, discoloration, or exposed wound edges before applying any type of bandage or binder. We would then cover the exposed wound or open abrasions with the sterile dressing. Assess the condition of underlying dressings and change if soiled. After you apply a dressing, assess, document, and immediately report any changes in circulation, comfort level, body function such as ventilation, and skin integrity. Now, when I talked about body function such as ventilation, when we apply a binder, an example would be an abdominal binder. It is a tight piece of material that is placed around the abdomen, and this can affect somebody's respiratory status or ventilatory capacity, meaning their ability to take deep breaths. We want to make sure that we explain to the patient that any dressing or binder will feel relatively firm or tight. We also want to let them know that we are going to assess the dressing carefully to be assured that it is applied properly and it is providing a therapeutic benefit, and that we will replace the dressing if it ever does become soiled. As I was talking before, this is an example of an abdominal binder. Binders are especially designed for the body part to be supported. The most common types of binders are an abdominal binder as seen here, and as I previously mentioned, a sling. An abdominal binder supports large incisions that are vulnerable to stress when the patient moves or coughs. So an abdominal binder would be applied to prevent dehiscence or evisceration specifically. It is a rectangular piece of cotton or elasticized material, so elastic material, with many tails attached to the two longer sides or long extensions on each side to surround the abdomen. So it's a big elastic piece that goes around the abdomen, and the one end will then connect to the other end. And you have the option of making it tighter or looser. Slings help support arms with muscular sprains or fractures. A commercially made sling consists of a long sleeve that extends to the elbow and a strap that fits around the neck. In the home, patients can use a large triangular piece of cloth as a sling. It is important that when we are applying a sling, we want to prevent the formation of dependent edema. And edema, we talked before, is swelling. And dependent edema is, think of gravity. So if I have my arm up to my chest, as we have in the picture here, I'm going to help prevent dependent edema. If my arm is immobilized or a sling is applied with my arm down at my waist, gravity is going to pull all the fluid down to my wrist and hand area, and I would then have what is called dependent edema. So it is really important to make sure that the lower arm is always supported at a level above the elbow to help prevent dependent edema. Rolls of dressing secure or support dressings over irregularly shaped body parts. Each roll has a free outer end and a terminal end at the center, so think of like an ace bandage. The rolled portion of the dressing is its body, and you place its outer surface against the patient's skin or dressing. So this would either be an ace bandage when we talk about a roll of dressing, or it could even be something called cling, which is sort of a roll of gauze. And we will learn how to utilize this once we get into the lab in a few weeks. So don't get too hung up on the proper technique of applying an ace bandage or a roll of dressing. Heat and cold therapy is applied to an injured body part to provide therapeutic benefits. Before beginning therapy, you need to identify and understand the normal body responses to local temperature variations. Heat therapy is best used for patients afflicted with degenerative joint disease, localized muscle strain, menstrual cramping, hemorrhoid and perianal inflammation, and local abscesses. Cold therapy is best used for patients afflicted with a sprain, strain, fracture, muscle spasm, superficial laceration, minor burn, arthritis, after an injection, or joint trauma. Education is necessary when using heat or cold therapy. Patients who have decreased sensations should be very careful when using these therapies. So I know there is a lot of information on this slide that seems very confusing, and all I want you to know is that patients who have decreased sensations, we need to be very careful when applying heat or cold to them, because they may not be able to identify when it gets too hot or too cold, therefore an injury can occur. And that heat therapy is best for patients with degenerative joint diseases, localized muscle strain, menstrual cramping, hemorrhoid and perianal inflammation, and for local abscesses. Cold therapy is used best for patients with a sprain, a strain, fracture, muscle spasm, superficial laceration, minor burn, arthritis, after an injection, or joint trauma. A physician's order is required before heat and cold therapy can be applied. Assessments before, during, and after therapy is needed, along with proper documentation. Use your specific healthcare institution's policy and procedures when using different types of therapies. The response of the body to heat and cold therapies depends on the following factors. Duration of application. A person is better able to tolerate short exposures to any temperature extremes. Body part. The neck, inner aspect of the wrist and forearm, and perineal regions are more sensitive to temperature variations. The foot and the palm of the hand are less sensitive. 3. Damage to body surface. Exposed skin layers are more sensitive to temperature variations. Prior skin temperature. The body responds best to minor temperature adjustments. Body surface area. A person is less tolerant of temperature changes over a large area of the body. So, I would be more tolerant if I put my hand in a bucket of ice water versus doing the polar bear plunge and putting my whole body into a freezing cold ocean or body of water. Age and physical condition. The very young and old are most sensitive to heat and cold. If a patient's physical condition reduces the reception or perception of sensory stimuli, the tolerance to temperature extremes is high, but the risk for injury is also high. So, for example, if I had a patient who had some sensory impairment and I provided a heating pad to them, they would maybe be able to tolerate a very hot heating pad. However, because they didn't have the correct perception of that heat, they are more likely to be injured or to be burned by that very hot heating pad. So, before applying heat or cold therapies, first observe the area that you will treat so you are able to evaluate therapy-related skin changes. Identify conditions that contraindicate heat or cold therapy. Assess the patient's sensory function and ability to recognize when heat or cold becomes excessive. And finally, assess the condition of all equipment used, checking for cracked cords, frayed wires, damaged insulation, exposed heating components, leaks, and evenness of temperature distribution. It is really important when providing heat or cold therapy to a patient. Allow them to feel empowered or independent. Provide them with a timer. You don't want to place a patient on a heating pad for 3 hours. Doing it in small increments of time would be most beneficial and also decrease the risk for injury. So set a timer, maybe 30 minutes or 15 minutes, and allow the patient, especially if they have impaired sensory perception, to notify you that the timer has expired and it is now time to either switch positions of the heating pad or take a break. It is also important to provide privacy during application of heat or cold therapy. Depending on where I am applying the heat or cold therapy, certain body parts may be exposed. So pulling a curtain or closing a door is very important in providing privacy and providing dignity to your patients. Before applying application of heat or cold therapy, make sure the patient understands its purpose. Also make sure they understand the symptoms of temperature exposure and the precautions taken to prevent injury. We talked before that a healthcare provider's order is an absolute must before applying heat or cold application. The correct temperature to use for heat and cold applications varies according to agency policies. You administer heat and cold applications in dry or moist forms. Make sure to consider the type of wound or injury, location of the body part, and presence of drainage or inflammation when selecting dry or moist applications. These are some examples of heat and cold therapy. A warm, moist compress improves circulation, relieves edema, and promotes a concentration of pus and drainage. A compress is a piece of gauze dressing moistened in a prescribed warmed solution. To maintain a constant temperature, change the compress frequently or apply a waterproof heating pad over the compress. A layer of plastic wrap or a dry towel insulates the compress and retains the heat. Immersion of a body part in a warmed solution promotes circulation, lessens edema, increases muscle relaxation, and allows application of medicated solution. You also administer a soak by wrapping the body part in dressings and saturating them with warmed solution. After any soak, dry the body part thoroughly to prevent maceration. The patient who has had rectal surgery or an episiotomy during childbirth, or who has painful hemorrhoids or vaginal inflammation, benefits from a sitz bath, a bath in which only the pelvic area is immersed in warm fluid. The patient sits in a special tub or chair, or in a basin that fits on the toilet, so the legs and feet remain out of the water. Commercially prepared disposable hot packs apply warm, dry heat to an injured area. Follow package directions for activating packs and recommended time for application. The hot water bottle is an economical means of applying heat to an injured body part. Many patients use them in the home. Never apply a water bottle directly to the skin surface. Cover it with a towel or pillowcase. Another conventional form of heat therapy is the heating pad, an electric coil enclosed within a waterproof pad covered with cotton or flannel cloth. Advise patients to avoid using the high setting and to never lie on the pad. We are now going to discuss cold therapies. Apply cold, moist compresses for 20 minutes at a temperature of 15 degrees Celsius or 59 degrees Fahrenheit to relieve inflammation and swelling. Do not get hung up on the temperature for that at all. But note cold compress and cold, moist compress for 20 minutes to relieve inflammation and swelling. Compresses are clean or sterile. Observe for adverse reactions such as burning or numbness, mottling of the skin, which is like a purplish bluish coloring of the skin, redness, extreme paleness, or a bluish skin discoloration. The procedure for preparing cold soaks and immersing a body part is the same as for warm soaks. Take precautions to protect the patient from chilling. For a patient who has a muscle sprain, localized hemorrhage, or hematoma, or has undergone dental surgery, an ice bag is ideal to prevent edema formation, control bleeding, and anesthetize or help numb the body part. Cover the bag with a flannel cover, towel, or pillowcase. Apply the bag to the injury site for 20 to 30 minutes. You may reapply it in an hour. Commercially prepared single-use ice packs come in various sizes and shapes. When you squeeze or knead the pack, an alcohol-based solution is released inside to create the cold temperature. The soft outer coverings are usually safe to apply directly to the skin surface. Some chronic wounds are the result of underlying pathological conditions that continue long after wound healing occurs. Healing for a pressure ulcer or a chronic wound is lengthy and requires continuity of care from the acute care setting to the restorative care setting. In this setting, you use many of the principles and interventions detailed in the acute care section. Continue diligent assessment to identify patients at risk for impaired skin integrity and institute preventative measures as needed. Despite efforts with wound care, wound healing will not occur if the patient is malnourished. Tissue repair requires more protein, carbohydrates, fats, vitamins, minerals, water, and oxygen than normal tissue metabolism. The delivery of nutritional substances to tissues depends on a healthy circulatory system. Malnutrition causes an insufficient supply of the necessary nutritional elements and alterations in blood vessel integrity. Be sure to work closely with registered dietitians to provide a well-balanced diet and educate patients about the importance of good dietary habits. The surgical patient who is well nourished and has no complications requires at least 0.8 grams of protein per kilogram daily for nutritional maintenance. And don't get hung up on that number specifically. Just know that you need more protein to promote wound healing. For patients weakened or debilitated by illness, supportive nutritional therapies are necessary. Supplemental tube feedings introduce nutrients directly into the gastrointestinal tract. So if a patient is unable to tolerate these tube feedings or enteral feedings, a healthcare provider often orders parenteral or intravenous administered nutrition. So nutrition that would go through their IV versus a tube that was either goes right into their GI tract via their belly or a tube that goes down their nose and into their stomach to help feed them. So if maybe the patient isn't able to tolerate the tube feeding, then the healthcare provider would order an IV type of nutrition. Sorry about that. The patient with a wound that restricts mobility or has the potential to compromise the function of a joint sometimes requires additional physical and/or occupational therapy. So therefore, somebody who has limited mobility, physical limitations, they may require physical and/or occupational therapy. Make sure to work closely with a physical therapist to monitor a patient's activity and tolerance for exercise. It is important to optimize activity within a patient's physical limitations and return function as rapidly as possible. Returning back to our case study, in preparation for her husband's discharge, Mrs. Ahmed is interested in learning how to change Mr. Ahmed's pressure ulcer dressing. Linda develops a teaching plan to include Mrs. Ahmed with the outcome goal that, at the end of the teaching session, Mrs. Ahmed will perform an acceptable return demonstration of dressing application. So, some possible teaching strategies that we can apply with Mrs. Ahmed are: schedule time when Mrs. Ahmed is present and be prepared to spend 30 minutes in 2 separate teaching sessions. Avoid using words that Mrs. Ahmed will not understand. So stay away from the medical lingo and try to make it as easy to understand as possible. Provide a brief description of what will be taught to both the patient and the spouse. Include the patient in all of the teaching, even though he is unable to see the wound. Bring an extra dressing to the bedside to show Mrs. Ahmed what the dressing looks like and how to apply it. Use a pictorial guide of a pressure ulcer to help Mrs. Ahmed understand what the wound looks like and how it will progress if it shows signs of healing. So show her pictures of what a stage 2 wound looks like now and the process of it healing so she can see One, is what she's doing working? Is her husband's wound healing? And she'll also be able to see what the eventual goal or outcome will be. Plan one session in which Mrs. Ahmed will watch a demonstration of the wound being cleansed and the dressing applied. Plan a second session in which she will do a return demonstration. At the end of each session, ask Mrs. Ahmed how she felt doing the dressing, and include Mrs. Ahmed in this evaluation. I also find that it is really important to write information down for the patient, because you may show them and they may do a return demonstration, but once they get home, they may forget. So making sure to have all of the steps written down for Mrs. Ahmed is also very helpful. What teaching and evaluation strategies would be appropriate? So we talked about the teaching strategies. Now let's talk about the evaluation strategies. Ask Mrs. Ahmed questions as she does the procedure to evaluate her understanding of each step. So why are you doing this, Mrs. Ahmed? Which step would you do next, Mrs. Ahmed? Ask Mrs. Ahmed what she will evaluate at each dressing change. So what is she looking for? Is she looking for the wound to heal? What particularly is she looking for? Less drainage, more granulation tissue, approximation of the edges of the wound. Also, observe Mrs. Ahmed changing the dressing and cleansing the wound. Observe any body language that indicates how she is feeling while doing the procedure. If she's making a face where she's scrunching up her nose and kind of looking away, she may feel disgusted while cleansing the wound. It's really important for us to confront Mrs. Ahmed about this and try to make her as comfortable as possible while performing this procedure for her husband. Linda, the nurse, observed Mrs. Ahmed's wound and measures it to be 1 by 1 inch with serous drainage and red color. Achievement of outcome by improved tissue type and reduced wound size. So our goal was to reduce the wound size, and we actually were able to do that throughout this case study. Linda palpates underlying skin around the wound. The skin remains intact. Achievement of outcome by no evidence of advancing ulcer or tissue damage. She asks Mr. Ahmed about discomfort. He denies any new sensations at the wound site. Achievement of outcome by no evidence of new tissue damage. What other means of evaluation can Linda be using? So Linda may also use Mr. Ahmed's nutritional status as an evaluation tool. She may ask Mr. Ahmed about his food intake and review his calorie count over the last week. He reports that his appetite is increasing and he is eating most of his meals. Calorie count shows a steady increase in daily consumption. The outcome has been achieved as noted by improved nutritional intake. And now to continue on the evaluation portion of the nursing process. You evaluate nursing interventions for reducing and treating pressure ulcers by determining a patient's response to nursing therapies or nursing interventions and determining whether you achieved each goal. In addition, evaluate a patient's and family's need for additional support services and initiate the referral process when needed. A patient and caregiver need to understand how to prevent or treat pressure ulcers. Some patients enter into the wound healing phase with unrealistic expectations regarding duration of care. Ask the patient if the treatment has met his or her expectations. Linda Abraham has completed her clinical experience with Mr. Ahmed. His pressure ulcer is still present, but it is reduced in size and demonstrates progress toward healing. No other sites of non-blanchable erythema are noted, and the rest of his skin remains intact. Linda teaches Mrs. Ahmed how to assess her husband's skin for signs of increased risk for or further breakdown. Linda, with the help of her instructor, devises a plan of care for the home, and they are meeting with the home care nurse today when she visits Mr. Ahmed at the hospital. This concludes the remaining lecture for Chapter 37, Skin Integrity and Wound Care.